Descemet membrane endothelial keratoplasty or DMEK has the advantage of faster visual recovery, better visual quality and more physiological replacement of the diseased endothelium as compared with Descemet. The initial learning curve is surgically challenging owing to difficulties faced during tissue handling of the thin Descemet endothelial complex. Problems may be faced during graft preparation, leading to tears and tissue loss. Graft insertion and unfolding may be challenging even in experienced hands. The DMEK graft conventionally assumes a double roll configuration with the endothelium outside. The rolls face upwards when the graft is correctly oriented. In the incorrect orientation of DMEK graft or upside down graft, the rolls face downwards with the endothelium towards the stoma. Various clinical signs have been described to assess the correct orientation of DMEK roll. The most serious sign involves inserting a cannula anterior to DMEK graft and moving it sideways gently under the roll. If the cannula appears blue, the graft is correctly oriented with the rolls facing upwards. If the cannula does not appear blue, the graft is likely upside down. Many surgeons employ S or F stamp to confirm correct orientation after graft unfolding. The Minute sign is a triangle-shaped configuration of the partially unfolded DMEK graft with the membrane folded in. Intraoperative optical coherence tomography or IOCT is a useful tool to observe in vivo graft orientation and facilitate correct unfolding and complete attachment of DMEK roll. In this video, we describe the utility of intra-OCT to effectively tackle various challenging scenarios during graft insertion and attachment. The process of unfolding the DMEK graft involves achieving a double roll configuration with the rolls facing upward, gentle tapping maneuvers to achieve unfolding of the graft, and injection of air under the graft after unfolding it to achieve graft apposition. In this video, a tight DMEK scroll with a single roll configuration was observed after graft insertion on IOCT. Young age of donor predisposes to a tight roll formation. IOCT helps assess the configuration of DMEK graft and the utility of surgical maneuvers in the correctly unfolding the graft. Gently decompressing the antechamber to maintain a relatively shallow AC and tapping maneuvers with the cannula on the corneal surface helped to tight scroll to unfold into a partial double roll configuration with the roll facing upwards. An IOCT helped to confirm the correct orientation. Thereafter, air was injected under the DMEK graft after it was nearly completely unfolded. The attachment of graft was observed in real time with IOCT. Gentle, sweeping movements on the corneal surface were performed to help remove interface fluid and achieve a well-attached DMEK graft. In this case, a single scroll was observed on injecting the DMEK graft, which assumed the double roll configuration after slight manipulation. However, the graft was oriented upside down with the rolls facing downwards. In such scenario, injecting balanced salt solution in anterior chamber creates a fluid wave in antechamber which helps in flipping the graft and assuming a correct orientation. The graft may become partially unfolded during this maneuver, as in this case. An IOCT is indispensable to assess the correct orientation of partially unfolded graft. Air is injected after complete unfolding of graft, and AIOCD helps to assess completion of the unfolding even in the periphery, and complete apposition can be seen with the help of AIOCD of the DMEC graft. Sometimes a small peripheral folds may be present in DMEC graft, which may be nearly impossible to unfold after injection of air. AIOCD helps pick up peripheral areas of DMEC folds which may not be visible on microscope alone. AIOCD is also an invaluable tool in cases of DMEC that requires debubbling. The thin membrane with areas of detachment can be easily visualized on AIOCD, and complete attachment of a Descemet membrane complex can be confirmed after air injection. In all cases, the graft was well attached in the post-operative period with optimal visual and anatomical outcome in these cases. Complete apposition of graft on a corneal stoma was confirmed on anti-segment OCT. To conclude, gentle, patient manipulation in a relatively shallow antechamber are required to achieve graft unfolding and attachment of DMEC root. An intraoperative OCT is a useful adjunct to assess correct graft orientation in this technically challenging surgical procedure. Optimal visual and anatomical outcomes may be achieved even in the initial learning curve with AIOCD guided DMEC.